played a very prominent role in promoting the subspecialty of emergency radiology in our country. Now, emergency radiology is a neglected field. It is just coming up because it is a very essential field. It is one of the areas where you cannot afford to go wrong because it is a question of life and death or a very critical area time is involved. Plus, you don't have the benefit of having your colleagues around you in emergency settings. If you are a resident, you may not have your consultants there to help you or other seniors to help you. And this is the time where you really need to be on alert and you can't afford to make mistakes. And National Board also would like to, welcome ma'am because this is a field which we would like her, presence again and again to help our trainees and us to deal with this important field. And today she is going to be presenting some spotters a little interactively on or some cases which she feel one cannot afford to miss in emergency radiology. And these are the things which you as trainees cannot afford to miss. So again, a very warm welcome, Dr. Anjali, and this thing is all yours, ma'am.
Thank you very much, Dr. Anjali, for the invitation and for organizing this platform. It's really an honor, and I take this as a privilege as a radiologist, as a professional, showing cases to residents and discussing them. So the format is quite informal, and I would do a case-based approach of cases that I've encountered in my practice and cases, as Dr. Anjali mentioned, we should be able to give some hint to the clinician or to the emergency room physician or trauma or emergency room surgeons so that they can initiate the right management in a timely manner. And I just want to reiterate what she's already mentioned. In emergency department and radiology, patients are acutely ill and it's often a life and death situation. So that's why you need to make very precise and timely diagnoses, as the patient's outcomes are, time dependent. You need to abide by the golden hour of critical trauma. And you know that in stroke patients, time is brain. And the workflows are very unpredictable. So your reports or your impressions that you communicate to your emergency room colleagues or seniors, juniors, that needs to be very precise in terms of, is there a bleed? Is there not a bleed? Does this patient need surgery or no surgery? So you really should not or try avoid hedging in the emergency room. And this is going to be a head-to-toe case review. Unfortunately, because of paucity of time, I have not gone beyond the chest, just touch the chest, and maybe in subsequent sessions, or if there are other speakers, they can talk more on abdomen, pelvis, and the small parts. And I'll just highlight salient principles. We'll also go into a few nuances of making these diagnoses and differentiating from other entities. And as I mentioned, we want to make sure that we avoid any loss of life, limb, organ, or permanent damage. So our case one, and I request all the participants to please use the chat box to put in their responses. And I will just check the chat box. If you have any questions, you feel free to ask questions as we go along. This is a 32-year-old male with new onset dysarthria, nausea, vomiting, and patient had left-sided weakness. And then the patient became unconscious with decerebrate posturing. And all this happened in the emergency room over a course of a few hours. So I want to look at the CT, one single axial section of the head. And is it a contrast enhanced CT or a non-contrast CT? That's the first thing we want to comment upon. So you guys think it's an NCCT or a CECT? And since I have contrast enhanced, okay, and NCCT, okay, great. So it's a mixed response. I just want to mention that, it is not your fault. It is very difficult to make the, this thing, whether it's contrast and non-contrast, since it's a single image. But what you can see is that, this MCA on the left side is not dense. If you look at the sinuses, they're not really dense. The dura, it's not enhancing. And however, you see this dense basilar artery. So that's why we are confused. And I would say that this is a non-contra CT since, I can see the MCA and the Sylvian branches of the left MCA, the dura, which are not enhancing. So on a non-contra CT, most of you have got it right. This is a hyperdense basilar artery. And I have now two axial images of the non-contra CT head. The image which is inferior to the one that I showed in the previous slide, which is showing a normal appearing basilar artery, not dense, and the MCA that you can see on this image. And the very next image near the tip of the basilar, you see a hyperdense basilar, and the MCA is normal in density. So this is a dense basilar artery. And I do not see any acute infarct on the CT scan. And the MRI showed restricted diffusion on the left side of the pons and also in the cerebellum bilaterally, suggestive of acute infarcts, so posterior circulation infarcts. And please remember, CT is usually the initial imaging modality, in patients who walk in with acute strokes. So one must be very familiar with how to make a diagnosis of an acute or a hyperacute stroke, as the CT signs are quite subtle early on. Now, this patient underwent a CT angiography, and you can nicely see non-contrast CT and a contrast enhanced. The basilar artery is not enhancing, unlike the other cortical branches and the superficial cortical veins that are enhancing very well. So basilar artery strokes, they comprise 1% of all strokes, a very small percentage. And the causes are primarily three. You can get thromboembolism, atherosclerosis, or dissection. And usually when you see in the distal third of the basilar artery, it's usually thromboembolism. The atherosclerotic occlusions tend to be in strokes, they comprise 1% of all strokes, a very small percentage. And the causes are primarily three. You can get thromboembolism, atherosclerosis, or dissection. And usually when you see in the distal third of the basilar artery, it's usually thromboembolism. The atherosclerotic occlusions tend to be in disease vessels where you might see atherosclerotic plaques at the vertebrobasilar junction or in the proximal or mid part. And the dissection is very unusual in the intracranial portion of the basilar artery. It is, usually seen more commonly in the extracranial part of the vertebral arteries. And so just another question, hyperdense vessel sign. I want you to tell me which of the following is false. So choice 1, it indicates an acute clot due to a thrombus or embolus. True or false? Increased density due to extrusion of plasma and increased hematocrit level. It is one of the earliest signs of acute ischemic stroke. D, it is very sensitive but low on specificity. So which of the following is false? So the question is, which one is false? Yes, Dr. Murthy has mentioned A is true. That is true. But I want you to tell me which of the following is false. So there is only one false statement. The rest are all true. So in the interest of time, I don't see any. Okay, I do see many responses. I'm sorry, I missed that. Okay, excellent. Yeah, so we have Dr. Sarvana, Dr. Gaurav, Dr. Deepak, Dr. Vikas. Excellent. Going for D. Yes, that is right. It is quite specific, almost 95%, but the sensitivity is just moderate at 52%. And it is one of the earliest signs of acute ischemic stroke that can be seen within 90 minutes of onset of symptoms. And the A and B are true. As you know, time is of the essence, so we need to act fast. And we need to communicate really fast to the emergency room physicians that, this patient has an acute stroke so that they can institute intravenous thrombolysis in case there is no hemorrhage on a non-contrast CT. Now, this one, 69-year-old male who's unresponsive, and I just want to show you a companion case. You're seeing the dense MCA sign here on the left side, hyperdense MCA compared to the contralateral little portion of the right MCA that you're seeing. And this is an indicator of an occluding clot in patients who have acute ischemia on a non-contrast CT. And as you can see, there are no definite parenchymal changes. Once you see this finding, usually the patients, if it's a tertiary care, a good stroke team is in place, straight away you either do a CT angiogram on the table and straight away to a neurointerventional procedure after confirming the presence of a clot. More signs in the elderly female with altered mental status. And the CT was done. And then 30 minutes later, another CT was done at the bottom row because the patient was developing a decreasing level of consciousness in the emergency room. So the initial CT was reported as negative. And so on a retrospective analysis, you can see that there is slight asymmetry between the right and the left side. So if you look at the left cortex, it looks quite bright, white, compared to the right frontoparietal cortex, which is looking slightly hypodense. And this difference is more obvious on the 30-minute follow-up scan, where you can see that there is effacement of the corticomedullary differentiation on the right side. compared to the left side, which is looking normal. And there's another very subtle sign. You can see this hyperdensity, a dense dot in the sulcus. So this is the dot sign, the MCA dot sign, which is indicative of a clot in a cortical branch of the MCA. Excellent. Yeah, I see the cortical ribbon sign. Good. So I've just put in a magnified image to demonstrate the MCA dot sign. So, in younger patients, this is an elderly patient, but, when you see this dot, which is isolated, be very careful in the appropriate clinical setting. More signs, you can see the insular ribbon sign where there is loss of the gray-white interface in the insular cortex, and that is also an early CT sign of a middle cerebral artery territory infarct. You may see slight blurring of the basal ganglia in cases of early MCA ischemia. And sometimes the basal ganglia may appear completely hypodense, which is the disappearing basal ganglia sign. And please note, you can see that I'm using the stroke windows to highlight these findings. So when you are at the CT console, or if some of you who do have, where your departments have PACS workstations, do play around with the window settings and try to use the stroke window, which is a narrower window width, and then compare both sides of the brain. And they need to be symmetrical. If you see asymmetry, that should be an alert for you that something is not right. Another patient, elderly female with altered mental status, acute stroke, weakness. She's hypertensive and diabetic. So when you look at the CT scan, it's a non-contrast CT scan of the head, nothing really strikes you, maybe, there's no, it looks quite symmetrical, density looks fine. So is it normal? Is it abnormal? Are you going to send the patient back that, we don't see anything, or no? Or are you going to do a contrast enhanced CT? Are you going to do an MRI? You have both CT and MR functioning when the patient just got the scan done. So there's nothing here, no focal sign symptoms. You could do either. You could do a CT angiography of the head and look for the vessels. Perhaps you're missing vessel occlusion, but that's unlikely, given that there are no hyperdense vessels, no cortical signs for you to see a large vessel occlusion. So this patient underwent an MRI, and you have the diffusion weighted images at the top and the ADC map in the bottom row. And what you can see is, yes, good, Shipra. Yeah, you went for diffusion weighted MRI. Excellent. So what you are seeing is basically multiple foci of restricted diffusion. They are scattered bilaterally, and they're involving multiple vascular territories, the posterior circulation, the middle cerebral, the anterior cerebral artery circulation, and just randomly distributed at the cortex. And there is corresponding decreased signal on the ADC map. Look at the cerebellum, decreased ADC signal here, decreased ADC signal. In the caudate nucleus on the left side, decreased ADC signal. In the corpus callosum, decreased. And here in the cortex also, it is decreased in the frontal and parietal cortices. So this patient, so what do you think is the etiology of these multiple infarcts? What should I do next? Do you think, yeah, good. Yeah, excellent. Chiranjeev, excellent. He says this is embolic, correct. So this is basically multiple small acute embolic infarcts. And somebody mentioned, Vikas says he wants to do an echo. Fair enough, yeah, ECG, and that's good. CT angio, okay. So it is embolic and most likely cardiac source. And please remember, in embolic blockage, of the symptoms are sudden in onset. They just come out of the blue, and they're maximal at the time of onset. And they usually are cardiogenic due to a thrombus in a left cardiac chamber, which is either a left ventricular pseudoaneurysm, aneurysm, or a dilated left atrium from atrial fibrillation. And you can rarely get paradoxical embolism from a DVT that is embolizing through an atrial septal or a ventricular septal defect. Now let's move on to our next case. This is a young female who has headache. She's postpartum, recent postpartum state. So this is, we have non-contrast axial CT images of the head. And what are you seeing? You're seeing these hypodensities ill-defined in the splenium of the corpus callosum, the periatrial white matter, relatively parasagittal in location in the parietal lobes, occipital lobes. And, they are sparing the cortex. It's involving the white matter. And if you notice, this is really not conforming to any specific arterial distribution. And I don't see any hemorrhage within this. So given the non-contrast CT, my differentials, that she's postpartum, so PRESS is a great thought. Yes, one could also consider cerebral venous thrombosis. And in the right clinical setting, an infiltrating glioma, it's crossing the midline, lymphoma, and hypoxic ischemic encephalopathy. So these are good differentials. And what do you want to do next? Hi, can you hear me? Hello? Hi, can you hear me? Okay, great. Sorry about that. So MRI brain for edema. Yes, that's excellent. Unfortunately, Dr. Amit, I don't have an MRI in this hospital. So I have a CT. So I went ahead, I mean, my referring, hospital, they went ahead and they did a post-contrast CT scan of the head. And now what do you see? So we have the non-contrast images that I showed earlier, and now in the bottom row are the contrast-enhanced axial CT images. So again, I see that there is no enhancement within the ill-defined white matter hypodensity that I saw on the non-contrast CT. And so this looks like vasogenic edema primarily. And there is an interesting finding that you can see on the post-contrast CT. Yes, excellent, Dr. Basu. Yeah. So Pratik, it is basically demonstrating a reverse delta sign where, you're seeing the enhancing dura and a filling defect in the superior sagittal sinus. So this patient has dural venous sinus thrombosis. And, just like the arterial territories, we should also be aware of the fact that there are territories that are being drained by the venous sinuses. And just to give you an idea, the the sagittal sinuses, the superior sinus is, this is the location, the inferior sagittal sinus, and then you have the straight sinus and the internal cerebral veins, if you're seeing involvement of the thalamus and the deeper gray nuclei. So yeah, the delta sign, yeah, excellent. So this case, patient had straight and sagittal sinus thrombosis. And as we all know that cerebral venous thrombosis is rare, but a very serious condition. It can cause vasogenic or cytotoxic edema, either one or sometimes a combination of both due to either thrombosis of the cortical vein or the dural sinus. And the findings, edema is because of tissue congestion. The vein is, the sinus is occluded. So there are veins that are draining into the dural sinus. They are not able to drain in. So you're going to get congestion of the brain parenchyma causing edema. And when you get increased intracranial pressure can happen if it's, the larger sinuses that are involved. And when congestion is even higher due to back pressure changes, you may see hemorrhage. And there are risk factors, but please do note that in a fair percentage, almost 20%, you can get dural sinus thrombosis without any risk factors. And the presentation is quite non-specific. The findings can be quite subtle on CT. And so you can only suggest a diagnosis if you know you are on a high alert. And MRI, MRV are the preferred modalities for diagnosing sinus thrombosis. The treatment is anticoagulation, and 50% of these findings are reversible if you institute treatment in a timely manner. Now, I want to show you a pitfall. This is the non-contrast CT, and this is a contrast-enhanced CT. And, on the non-contrast, you can see the hyperdense superior sagittal sinus. And on the post-contrast enhanced, you can see the filling defect, which is corresponding to the hyperdense sinus on the non-contrast. So this is a true empty delta sign. And now, this is another case with a non-contrast CT and a contrast-enhanced CT. This is a delayed examination of the head. And as you can see, you see the empty delta sign, but this is a pseudo empty delta sign because the contrast from the sinuses has washed off and you're just seeing an enhancing dura. There is no sinus thrombosis in this case. There is no hyperdensity on the non-contrast CT, but this is a simplistic view. This entity is quite complex, and depending upon the stage of evolution or the time at which you image the patient, you can get the contrast density of various Hounsfield units, depending on acute, subacute stage, and MRV is certainly a better modality to evaluate. More examples. I want to show you this 65-year-old male with headache and right arm deficit. And you're seeing basically this is a non-contrast CT of the head, and you're seeing focal, small parenchymal hematoma in the left parietal lobe white matter. Now that's an unusual place. When you see unusual appearing hematomas in the brain, it's not really involving the cortex. And you should look for the veins and the dural sinuses adjacent to the hematoma. Like in this case, you can see this hyperdense superior sagittal sinus, hyperdense cortical vein. So this patient has superior sagittal sinus thrombosis. The MRI was done, and it does show this edema on the FLAIR images and the non-enhancing sagittal sinus on the contrast enhanced examination. Another patient where you have this young lady had a recent C-section and she was complaining of occipital headache. And very interesting, if you look at this T2 weighted image, you can see, compare the two sides. And if you look at the sigmoid sinus, the transverse sinus, you can see that there is loss of flow void on the right side. And on the contrast enhanced examination, you can see there is a filling defect, the dura is enhancing, but there is no pacification of the transverse and the sigmoid sinus. This female with altered mental status, you can see hemorrhage in the posterior temporal lobe, and just right next to it, you can see the hyperdense transverse sinus and the superior sagittal sinus as well. So this patient has cases of dural sinus thrombosis. So we move on to our questions on cerebral venous thrombosis, and I want you to tell me which of these is false. Diagnosis is often missed or delayed. Hyperdense occluded venous sinus is seen in the majority. The superior sagittal sinus is the most commonly affected. Focal parenchymal edema with or without hemorrhage is seen in greater than 50% of cases. So I just want you to tell me which of these options is false. So 3 are true and 1 is false. So, okay, D, A, B. Okay, excellent. So Dr. Shipra says that hyperdense occluded venous sinus is seen in the majority. That is false, and that is correct. It is, although it is a classic finding of sinus in the brain, it's not really involving the cortex. And you should look for the veins and the dural sinuses adjacent to the hematoma. Like in this case, you can see this hyperdense superior sagittal sinus, hyperdense cortical vein. So this patient has superior sagittal sinus thrombosis. The MRI was done, and it does show this, edema on the FLAIR images and the non-enhancing sagittal sinus on the contrast-enhanced examination. Another patient where you have, this young lady had a recent C-section and she was complaining of occipital headache. And very interesting, if you look at this T2 weighted image, you can see, compare the two sides. And if you look at the sigmoid sinus, the transverse sinus, you can see that there is loss of flow void on the right side. And on the contrast enhanced examination, you can see there is a filling defect, the dura is enhancing, but there is no pacification of the transverse and the sigmoid sinus. This female with altered mental status, you can see hemorrhage in the posterior temporal lobe, and just right next to it, you can see the hyperdense transverse sinus and the superior sagittal sinus as well. So this patient has cases of dural sinus thrombosis. So we move on to our questions on cerebral venous thrombosis, and I want you to tell me which of these is false. Diagnosis is often missed or delayed. Hyperdense occluded venous sinus is seen in the majority. The superior sagittal sinus is the most commonly affected. Focal parenchymal edema with or without hemorrhage is seen in greater than 50% of cases. So I just want you to tell me which of these options is false. So 3 are true and 1 is false. So, okay, D, A, B. Okay, excellent. So Dr. Shipra says that hyperdense occluded venous sinus is seen in the majority. That is false, and that is correct. It is, although it is a classic finding of sinus CT. Unfortunately, it is seen only in a quarter of patients with cerebral venous thrombosis, about 20 to 25%. And the superior sagittal sinus indeed is the most commonly affected sinus, followed by the transverse sinus. You notice this is not CSF density. Now, someone mentions chronic. I want to ask you, do you think it's acute, chronic, or subacute? So firstly, why do we think these are subdural hematomas bilaterally? You can see that, the sulci don't reach all the way up to the calvarium. They stop short of the calvarium. So you know that there is a collection that's separating the brain parenchyma from the calvarium. It looks, to a novice, you might say, well, the cortex looks abnormally thickened, which is, not really the case. And there is a mass effect. You can see that the ventricles are compressed bilaterally. There's no midline shift, and there's no midline shift because they're bilateral symmetric subdural hematomas. So these are isodense subdural collections. Most likely, yes, you will be right that these are subacute subdural hematomas bilaterally, but be a little cautious. Sometimes in patients who have severe anemia or have an underlying coagulopathy, acute subdural hematomas can also look isodense. So they may not be bright because coagulopathy, then the blood is not going to be coagulate. And the same is true for in certain cases of hyperacute subdural hematoma, where the blood may not have coagulated at the time you imaged the patient. So yes, I think for the large part, you can just say these are most likely subacute bilateral subdural hematomas. Some companion cases, I have two patient's 58-year-old male who's unconscious. And here, this is a 5-year-old child who had a fall and has presented, and the CT has been done. So I want you to tell me, what are you seeing here? So in the 58-year-old male, what do you think this is? Okay, yeah, good. Yeah, good. So excellent. So I think most of you have got it right. You're saying that it is a subdural hematoma, 58-year-old one, along the left frontoparietal convexity. There is a midline shift, subfalcine herniation, and the subdural hematoma is also seen along the interhemispheric forks. And as you can see, the ventricle is compressed. Of course, there's midline shift as well. And the 5-year-old male has, there is a large scalp hematoma. So when you see a large scalp hematoma, please look at the calvarium underlying the scalp hematoma, and of course, look at the intracranial portion. This is fairly large. This is a biconvex collection, and there is a non-displaced fracture of the right parietal calvarium just beneath the large scalp hematoma. So this patient has a large epidural hematoma, of course, with a midline shift to the contralateral side. And the important finding in both these cases is, these cases are basically, they represent neurosurgical emergencies because of the sign that is demonstrated here is as someone described here very well, the swirl sign. Dr. Jain mentioned that. And the swirl sign is indicative of a hematoma that is actively increasing in size. And basically, the hypodense areas might correspond to sites of active extravasation or the spot sign that you may see on CT angiography studies. So, when you see this, that is a reason to panic and call for emergent neurosurgical attention and consult. Now, this patient, 54-year-old female, is unresponsive. And, the CT has been done, and they want to know, what do you see? Do you think there is subarachnoid hemorrhage or not? So the resident, who was on call, first-year resident, said, oh, there's subarachnoid hemorrhage. So he called us with this question, and so what does everyone think? You think there's subarachnoid hemorrhage or no? So I'm going to just go over the findings. And, you see these hyperdense extraaxial spaces, effaced cortical sulci, effaced basal cisterns, and there is relative loss of the gray-white matter differentiation. The ventricles are also effaced. So many of you have correctly mentioned that there is diffuse cerebral edema, and that is absolutely correct because patient has suffered from a hypoxic ischemic insult. And we have these findings of diffuse cerebral edema. And it's basically pseudo-subarachnoid hemorrhage. That's an imaging pitfall that's associated with diffuse cerebral edema. Yes, Chiranjeev, you're right. The white cerebellum sign is also seen, and this patient is probably brain dead. Other CT mimics of subarachnoid hemorrhage, in pyogenic leptomeningitis, you can see hyperdense extraaxial spaces as well as the basal cisterns. Patients who've undergone intrathecal contrast-related procedures or have been given high-dose IV contrast, that can sometimes leak into the subarachnoid spaces, which can appear dense. Hounsfield unit measurements can be useful. This is pseudo-subarachnoid hemorrhage would be around 29 to about 35 Hounsfield units compared to 60, 70 if it is real hemorrhage. And this appearance is a result of raised intracranial pressure, which is causing engorgement of the superficial venous structures. And the subarachnoid spaces fill with a much larger fraction of meninges and blood vessels compared to the CF spaces because of edema, the spaces have been compressed. And of course, this is accompanied by decreased attenuation of the brain parenchyma. Now, contrast that pseudo-subarachnoid hemorrhage with real subarachnoid hemorrhage. Here you can be very confident this is an obvious case, as there is also intraventricular hemorrhage and intraparenchymal hematoma. And you can see that the HU level is almost 51, 52 Hounsfield units. Now, this patient, 65-year-old male, is unresponsive, and they want us to rule out a CVA, cerebrovascular accident. So what do you people think? So this is a non-contrast CT of the head. Yes, excellent. The thalami are hypodense bilaterally. So that brings up a set of differentials with the hypodense thalami. Additionally, you're also seeing, yes, that's one of the possibilities. Oh, you're thinking of artery of Percheron, Dr. Chiranjeev. Yeah, excellent. That's one of the differentials. That's rather rare, but yeah, that's certainly one of the differentials. But what you can also see is, now let's not jump to, our diagnosis. Let's first look at the entire image. You have hypodense thalami, you have hypodense basal ganglia, and you also have hypodense cortex. And the sulcal spaces are effaced because, yes. So there is, I'm sorry. So there is reversal. Now I have more images. You have all the signs are demonstrated here in this patient of an entity which we should not miss and make a prompt diagnosis of. So let's look at the signs. You have the white cerebellar sign here, right? The white cerebellar sign. You have the hypodense basal ganglia and thalami, and the, as I mentioned, reversal of the normal CT attenuation of the cortex and the white matter. So cortex is dark and the white matter is bright, which is just the opposite of a normal head CT. And this is a case of severe global hypoxic ischemic brain injury. And I must tell you that the immaturity of the brain, the duration of insult, its severity, and the timing of imaging influence the findings that you will see on CT or MRI examinations. And profound hypoxia in older children and adults typically affects the gray matter. You know why? Because that is basically has the highest energy demands, the gray matter. So you get involvement of, as we are seeing in this case, the deep gray matter, cerebral cortex, cerebellum, hippocampi, because they are very metabolically very active regions and they get affected the most when patients are suffering from hypoxic ischemic injury to the brain. And diffusion weighted imaging is usually positive within the first few hours. But remember, in the emergency room, CT is readily accessible, often the first imaging modality. So you must be able to recognize this constellation of these signs and make a diagnosis. Now, this case is not that common, rather rare, but something that, you've seen it once, you will never miss it again. So that's why I decided to include that. This elderly female has history of hypertension and diabetes. And she, they were working her up for a stroke because she had left arm and bilateral leg numbness. So they first got a non-contrast CT head, and they got, which was negative. They also got a CT angiogram of the head and neck. And as I mentioned, CTA head was also negative. And, and then I get a call from the emergency room that, oh, the doctor really wants to talk to you. And the doctor mentioned the patient is developing worsening symptoms, worsening numbness and weakness in all extremities, in a span of like half an hour while the doctor was examining and talking to the patient and her relative. And so I said, well, CT angiogram is negative. I see nothing with the vessels. But when they mentioned this history, I looked at the CT angio images, and nothing really stands out, but only if you look at it carefully, you can see the subtle hyperdensity in the spinal canal. So please note not to miss out on the spinal canal when you have symptoms that might be indicative of a pathology in that location. And the acute onsets, rapid deterioration, and then luckily there was another scan that was done and a bit more slightly delayed images. As you can see, the veins are better opacified, and you see there is contrast pooling in the spinal canal, and this is in the epidural space. So there is a large epidural hematoma in the spinal canal. And, the patient was immediately wheeled to the OR, and the patient underwent laminectomy, and they removed 30 cc's of epidural hematoma, and they did a follow-up MRI because they didn't see anything on surgery or the path right away, but they did not find any tumor or AVM. So there was severe cord compression, as some of you mentioned, that caused the symptoms, and the rapidly expanding active bleed in the epidural space caused that sudden deterioration of the patient. So I just want to also highlight that clinical clues are very useful. If I had not spoken to the physician, I would have probably missed this case, and the patient would have ended up with paralysis or, even worse, involving all extremities. So clinical clues, please pay attention to whatever that's available and speak with your referring physicians, emergency room doctors, or your colleagues who have referred the patient to you. And this is a rare condition, but the most common intraspinal hematoma, because this space has a rich vascular plexus, and it's idiopathic in up to 40% of cases, and occurs because of sudden changes in pressure that can cause rupture of these valveless epidural venous plexi. And on CT, you can see the biconvex shaped hemorrhage within the spinal canal, which is closely abutting either the posterior arch or the vertebral body. And I'll show you images of subdural hematoma from the literature, where you might see a Mercedes-Benz sign. This is the subdural hematoma, and this is the the thecal sac that's compressed. And on the sagittal image, a STIR image, you can again see the acute hematoma, hyperintense signal, and this is in the subdural space. The CTs are very good in terms of distinguishing between epidural and subdural hematoma. In subdural, it is not closely abutting the neural, the posterior elements. You can see the preserved fat, unlike the epidural hematoma, where the fat is lost. Epidural hematoma closely abutting the vertebral body. So that's how you can distinguish the two. And in our case also, we didn't see the fat. Now, case 11, a 25-year-old male with fever and throat pain. And, you're seeing there is a lot of edema here in the oropharyngeal region. And you can see that the tonsils are enlarged, and there is edema in the parapharyngeal space. There's also retropharyngeal edema, some fluid here, and not to miss the filling defects in the neck veins. Look at this, multiple filling defects in these veins. So this patient had developed thrombophlebitis of the neck veins secondary to tonsillitis and this peritonsillar abscess. And the CT, this is basically images of the chest that were included in the CT of the neck. So we got a peek at the lungs, and the lungs show these cavitary lesions, peripherally located, and these represent septic emboli. And yes, Batul, you're right, this is a case of Lemierre syndrome. And it is due to an anaerobic oropharyngeal infection that's complicated by septic thrombophlebitis of the neck or facial veins, classically the jugular vein, and patients have bacteremia and they throw off septic emboli, and lungs are most commonly affected. So patients need prolonged antibiotics, drainage of abscess if that's there, but there is no consensus regarding the use of anticoagulants. Now, another patient with a stiff neck and sore throat. I have the sagittal recons from the CT of the neck, and I have the axial images. So I've put one bone window, soft tissue window, and the axial images. And patient has a sore throat. So, and what you're seeing is this fluid in the prevertebral space here. So there is a fluid, there's some edema fluid. You can see the widening of the prevertebral space here. And what you should also look for is this sort of relatively amorphous looking calcification anterior to the anterior arch of C1 and C2 seen on the axial images. And please note, this is a contrast enhanced study and the fluid is rather flattened out. It's not bulging, it's not under pressure. There are no enhancing walls. So how many of you think this is an abscess and we need to do something about it? And how many of you think, hey, no, like, oh, this is just totally fine. Let's send the patient home. So should the patient go home, or do you think the patient needs further workup or some kind of antibiotics or cultures? Further workup, Vikas. Okay. Well, actually, this is a classic case of a condition where you get these elongated irregular calcifications at C1, C2 level. As I mentioned, the prevertebral space fluid is quite ill-defined. There's no wall enhancement, and there is no evidence of any inflammation anywhere except for this fluid and this calcification. So this is a diagnostic of a condition. And a second case here that I'm going to show to you, a younger female with neck pain and stiffness, and she had a fall from a staircase a week prior to presentation, and she's coming to the ER with a limited neck movement. So how many of you think it's a fracture? I can show you there is this ossification here, anterior to C1, C2, and I see a little bit of prevertebral fluid. How many of you think it's a fracture? Yes or no? No, excellent. Yeah, it is not a fracture. Yes, good. So majority of you think it's not a fracture, which is absolutely correct. And these are examples of cases of acute calcific tendinitis of the longus colli, which is a benign and unusual cause of acute neck pain and stiffness. What happens is, you get the calcium hydroxyapatite crystal deposition in the superior oblique tendon of the longus colli muscles. And that causes inflammation, irritation, and prevertebral space edema of fluid. And it is a mimicker of more serious conditions such as a retropharyngeal abscess, spondylodiscitis, or trauma. And recognition is important, as you can prevent unnecessary intervention. You can send the patient safely home just on NSAIDs. So painkillers and anti-inflammatory agents are good enough. And a diagram to show you what the insertions of, oh my God, this thing is hanging out. Oh, sorry, did I? Aha. Sorry about that. Let me just see what happened. Okay. Can you all see my slide now?
Yes, Dr. Anjali.
prevertebral space edema of fluid. And it is a mimicker of more serious conditions such as a retropharyngeal abscess, spondylodiscitis, or trauma. And recognition is important, as you can prevent unnecessary intervention. You can send the patient safely home just on NSAIDs. So painkillers and anti-inflammatory agents are good enough. And a diagram to show you what the insertions of, oh my God, this thing is hanging out. Oh, sorry, did I? Aha. Sorry about that. Let me just see what happened. Okay. Can you all see my slide now?
Yes, Dr. Anjali. Yes, Dr. Anjali.
This muscle, where it's inserting into the anterior tubercle of C1. And when that gets inflamed, you get tendonitis. Now, this patient was presented, was unresponsive, was brought in unresponsive, and is a known blood pressure was high. And the non-contrast CT head, that's what it looked like. So totally, washed out brain parenchymal differentiation, corticomedullary differentiation is effaced, and the sulcal spaces are lost. The ventricles are also appear chinked. So there is diffuse edema, and patient has hypoxic ischemic encephalopathy. And what is the underlying cause? Patient is hypertensive, and they were suspecting perhaps aortic dissection. And this is what the CT angiogram of the neck, chest, you can see abdomen. So here, I'm going to just go back. Look at the kidney on the left side. It's hypodense compared to the right side. Look at the flap that's extending. So it's basically a case of aortic dissection. So what type of dissection it is? Stanford type A or type B? So this is a type A dissection. Yes, yes, excellent. Type A dissection. Most of you have answered it correctly. It's involving the ascending aorta. So it's a Stanford type A dissection. And the patient had hypoxic ischemic encephalopathy because look at the carotid arteries. Look at this. The flap is involving all the arch vessels, and the carotid arteries are severely narrowed in caliber. Look at the true lumen. It's really small. So the perfusion is really compromised to the brain. And of course, there is also compromised perfusion to the kidney and other viscera. So, this is the other interesting finding that I wanted to show to you is not to forget, look at the pulmonary artery. That's also small compared to its normal caliber. And you see this hyperdense collection around the pulmonary artery. So there is also, intramural pulmonary artery hematoma in addition to aortic dissection. So Stanford type aortic dissection, intramural pulmonary artery hematoma, and branch vessel compromise. And I just want to highlight, you might see this once in a while, and that's because the ascending aorta and the main pulmonary artery, share a common sheath, and so the extravasated blood from the ascending aorta can extend beneath the adventitia of the main pulmonary artery, cause narrowing of its lumen, as this is a low pressure circulation, and then extend further along the pulmonary interstitium. Sometimes patients can also develop pulmonary hemorrhages as a result of this condition. And you've all got it right, Stanford type A, type B. Rarely you may come across a dissection flap that extends up to the arch vessel, doesn't involve the ascending aorta. I've seen 2 or 3 such cases. And in that case, it doesn't change your management. This still remains a conservative management rather than surgical management. And you just call it a Stanford type B with involvement of the aortic arch. And with that, I'm going to end, and maybe we can take up the rest some other time. I'm happy to answer any questions.
Thank you, Dr. Anjali. That was a brilliant presentation, and you covered all the things that are important and should the residents must know, and some interesting cases also, especially the dissection and the longus coli case. Very interesting cases and good picks for the residents if they are able to do so. So if there are any questions, I will be happy to take them. I can't see any questions, Dr. Anjali. So with that, I would like to thank you on behalf of the National Board for this class, and we shall definitely would like to have you back on this platform to continue with this very important specialty, subspecialty of radiology, emergency radiology, and to teach our trainees more of what they should absolutely know. Thank you very much, ma'am.
Thank you, Dr. Anjali. Thank you very much for the opportunity, and it's a pleasure and an honor. And thank you to all the residents for participating. You were very involved with your responses in the chat box. So that's really, that's really nice. And you all did quite well. Thank you.
Thank you.
Thanks.